everybody. Welcome back. We are moving on to our next section, which is Airway. Congratulations to everyone passing the exam for AEMT. But now it's time to move on to our next section, and that will be Airway. And so before I introduce the chapter to you, it's something to think about that most medical malpractice comes from failure to maintain an airway. You've already been trained at the EMT level about maintaining an airway, and those skills that you learned as an EMT are going to apply as AEMT as well, those basic skills. And a lot of times it's those basic skills that allow you to maintain an airway. Really an advanced skill of maintaining an airway really takes away sometimes from the basic skills. So please, whatever you do, don't forget the basics. Used to have a medical director used to say that the airway emergency is over once the oral airway is in place. And, he was correct about that. And so something definitely to think about. But, think about, your dental procedures where calls go bad, patients die of hypoxia from local anesthesia. People go in for a simple procedure at their doctor's office and end up dead. And that's kind of how that happens, is they lose track of the airway itself. So let's talk about the function of the airway. So the function of the respiratory system, rather. So to obtain oxygen needed for cell metabolism, eliminate carbon dioxide, and produce by cell metabolism. So obtaining that 21% oxygen, bringing that into the system, and not just delivering oxygen to the cells. Again, that's 50% of it. The other 50% is the removal of waste. Let's look at the ventilation. Now, ventilation is completely different than the gas exchange process, right? Ventilation is mechanical process of moving air in and out of the lungs. So in order to have good ventilations, it requires a patent airway. All right, and so you have to also think about the other mechanical processes, which involved the integrity of the rib cage, the integrity of the sternum, the integrity of the intercostal muscles. So all of that is a mechanical process that's super important to ventilation. All right, and we're moving along here. So let's look at respiration. So respirations this is your actual gas exchange process. This is where gas exchange happens over the alveoli into the capillaries. Each gas diffuse for an area of higher concentration to that area of lower concentration. In this chapter 2, we're going to talk about problems with any aspect of ventilation, which is that mechanical process, or respiration, which is the gas exchange process that can quickly result in death. We are going to talk more about the compensatory ability and how it's limited, AEMT skills and a variety of techniques, from simple non-invasive, like the oral airway, to something more complex like an advanced airway. So airway ventilatory management, it requires that provider to use good, sound clinical judgment and critical thinking. All right, so you have to think about a lot. You have to think about the patient's condition, the amount and type of help available to you, factors that may complicate the situation, and short-term interventions versus a long-term solution. We're going to talk about all of those. So let's talk about external respirations. This can also be defined as pulmonary circulation, right? Oxygen, carbon dioxide exchange across respiratory membranes. And when we're talking about respiratory membranes, we're specifically talking about the alveolar and those pulmonary capillary walls. Internal respirations. This is the exchange of oxygen and carbon dioxide between the blood and cells, right? So what you're going to remember here is external respirations. Really, we're talking about the right side of the heart. We're talking about that deoxygenated blood coming back to the right side of the heart, going in the pulmonary artery, and leading to the lungs, to the capillaries for gas exchange. When we talk about internal respirations, we're talking about blood that's been oxygenated, has been sent back to the left side of the heart, right? Goes out the aorta, it's oxygenated, and goes out to feed those cells. Ventilation is required for external and internal respiration. And so what they're meaning here is that if I have an integrity problem with the rib cage, if I have problems with intercostal muscles, if I have a problem with the diaphragm, right, then I'm going to have a mechanical problem, and that mechanical problem is going to end up leading to a external respiration problem, to a gas exchange problem. The physiology of air movement. So ventilation. All right, so ventilation is controlled by levels of carbon dioxide, CO2, and oxygen, O2, in the blood and cerebrospinal fluid. This leads us right to talking about chemoreceptors, right? We have the primary chemoreceptors and the accessory chemoreceptors. The primary chemoreceptors are location. I'll get it right in a second, but the primary location, the body's monitoring of CO2 and its concentration occurs in the receptors located in the medulla. And that's what signals the inspiratory center in the medulla oblongata of the brainstem when carbon dioxide levels increase or oxygen levels decrease. And remember, we're on a carbonic drive. We're not on a normal healthy person is on a carbonic drive, not a oxygen drive, not a hypoxic drive. So these inspiratory centers, they stimulate the contraction of the diaphragm and the intercostal muscles, right? So that's why we have to think about that when we're dealing with someone with a cervical spine injury, right? We have to be aware of the phrenic nerve and where it's located. And we'll talk a little more about that here in a minute. But yeah, that's something that we have to be familiar with. So increased volumes of the thoracic cavity and lungs, air flows from that higher atmospheric pressure to lower intrapulmonary pressure, because what you have to remember is when that pressure drops, that causes that vacuum effect that allows that air and oxygen to actually reach the alveoli. It's that difference in atmospheric pressure from like 760 to 758. Stretch receptors. So these stretch receptors in the lungs send messages to the central nervous system that says, hey, don't breathe in so much air that you'll pop a lung. And that's what those stretch receptors are for. As the volume of the chest and lungs, chest returns to normal, as the volume of chest and lungs decrease, pressures within the lungs increase. Air flows from that higher intrapulmonary pressure to lower atmospheric pressure. Let's look at the upper airway. The structure above the glottis is considered the upper airway. We have your mouth and nose, your pharynx, which is your throat, right? You have two parts of that, the nasopharynx and oropharynx, talking about the part of your throat that is in contact with the nasal, like when you have sinus drainage and stuff like that. The hypopharynx or the laryngopharynx, the oral cavity, oropharynx, hypopharynx, they provide a passageway for digestive and respiratory systems. Here we have the oral cavity. Here, the oropharynx, hypopharynx. They're common passageway, again, for the digestive system. Helps you to avoid aspiration. The epiglottis would be your primary one there, but also you have your gag reflex, right? That hopefully stops something from going down between the vocal cords and into your trachea. The cough reflex. If something stimulates your vocal cords, it'll cause you to cough. And then even the elevation of the soft palate. So here's your nasopharynx right here. That's that part of your throat that comes in contact there. You travel down to your oral pharynx. Remember, your tongue is a big problem for airway compromise. There's your vallecula. And see, here's your laryngopharynx. And anything below that is considered your lower airway. Anything above that is considered your upper airway. So yeah, a certain degree of muscle tone is required to keep that tongue from relaxing and falling into the throat or pharynx, right? We lose muscle tone when we're unconscious, right? When a patient becomes unconscious, they lose that muscle tone, and so they're unable to maintain their airway just from the ability of controlling their tongue. So what is the most common cause for airway obstruction? Your tongue. Absolutely. So the lower airway begins at the glottic opening into the trachea. That trachea is going to bifurcate at the carina. And at the carina, you have the right side and left side. The bronchioles then divide and become bronchioles. And then at the end of the bronchioles, you find your alveoli. Here you can see that in this. You have your trachea. Right there is your carina, where it splits off into right and left. Bronchioles subdivide and become bronchioles. And then at the end of those bronchioles, here are your alveoli. So let's talk a little bit more about gas exchange. We have external expiration, internal respiration, and VQ mismatch. So ventilation, this is alveolar ventilation, included with tidal volume, minute volume, and dead space air. So when tidal volume decreases, the volume of dead space remains constant at expense of alveolar ventilation. It means you still have to take away 300 milliliters of dead space from whatever tidal volume that you have. Dead space is going to be constant. So you end up having to, it doesn't take a lot of lost tidal volume to where you're having a problem maintaining someone's gas exchange. Upper airway problem. So we have a decreased level of responsiveness. And I've always said that anytime in a scenario or in the real world, you approach someone that has an altered mental status, your primary concern in this call should be, is this patient's altered mental status affecting their airway, or can it affect their airway? And sometimes you have to keep going back to that, depending on your status of your patient. They may start off altered at, alert oriented ×2, right? But their level of consciousness continues to decrease to the point to where there's an airway issue. Foreign body airway obstruction, right? So is this a partial obstruction or full obstruction? Partial obstruction would be the patient still has the ability to cough and try to remove that on his own. It can be dangerous if you performed a Heimlich maneuver with this patient with a partial, because it could lead to a full airway obstruction. So that's the reason why we don't do the Heimlich maneuver on someone who can still have the ability to cough. And then active bleeding. So, the oral cavity is very vascular. And so if you had a patient with an altered mental status and they had some blood clots, well, that could definitely lead to an airway compromise. Lower airway obstruction. So this lower airway obstruction, right, is going to be from the, just below the glottic opening down, right, into the trachea and all that. So we're looking at the bronchioles, and we're looking at bronchial constriction, and that could be from an asthmatic patient or allergic reaction patient from anaphylaxis or asthma, where those bronchial spasms are so bad that we can't get oxygen past the bronchioles into the alveoli. Fluid or pus in the alveoli and bronchioles. So, we have to think about a pneumonia here, or a patient with pulmonary edema. If those alveoli have been blocked from gas exchange, then we're going to have a problem getting gas exchange if they're blocked. All right, trauma or problems that interfere with the ability to move chest wall or diaphragm. As I mentioned before, we have that mechanical process of breathing as well. And so if that patient has a problem with their diaphragm being injured, they have multiple rib fractures, they have intercostal muscle damage, all of that's going to take away that ability for the rib cage to expand and move out to allow the lungs to inflate. Paralysis of respiratory muscles. So we can talk about like a cord injury at T7 will disrupt the intercostal muscles at the thoracic level. The diaphragm is innervated by the phrenic nerve, which exists around C3 to C5, right? So, a spinal cord injury could be a major problem for the paralysis of the respiratory muscles and breathing, and that can be from trauma. Drug overdose, right? So, you have your heroin overdoses that decreases respiratory drive. That could be a problem. Respiratory disease, asthmatic, COPDers, emphysema, all of those respiratory disease patterns that can cause problems with respirations. So here we have abnormal respiratory sounds, and I was thinking when you're doing your primary assessment, what you're looking for is just when that primary is movement of air, but you're also want to make sure they have enough movement of air so that we know that they have at least an inch of chest rise and fall, but you're also listening, all right, and you're listening for those sounds that aren't supposed to be there. Snoring. So when we talk about snoring, we should learn this from our previous training, that we're talking about partial obstruction of the upper airway, right? So gurgling. Gurgling means they need to be suctioned, right? They have fluid in the upper airway. Stridor. Again, another upper respiratory sound. And this is from the partial upper airway obstruction. And this could be from laryngeal edema or even foreign body airway obstruction. Coughing, right? Wheezing. We talk about wheezing. Now we can talk about those lower airway obstructions. Right, lower airway from below the glottic opening down to the trachea. And so we're looking here, we're probably looking at bronchial constriction. And that's where that whistling noise comes from, the narrowing of the bronchioles. Crackles. All right, well, now we need to move a little further. Crackles are something that we hear that indicate fluid in the alveoli of those lower airways. So we move from the bronchioles down to the alveoli. And then bronchi. Bronchi, kind of the significance of that is it's that secretion in the bronchi, right? So it's wetness, a wet sound from the bronchi, and not so much of the wheeze. But you can have both wheezing and bronchi. So, every airway should be evaluated when we do that scene size up and that primary assessment. It's just super important that if there is an airway issue that we identify it early, that we correct any life threats to that airway. So let's talk about your general impression of your patient. It's so important. It's hard in the training department to make sure that we're painting a picture of a good general impression of a patient. That's definitely what we want to paint for you, so you'll know how to treat them. But in the field, we do that so that hopefully in the field you'll be looking to get a good general impression. So when we talk about like a fever, well, fever would mean the patient will have that flush color, right? Hypoxia, though, you could have the peripheral and circumluminal cyanosis. If you're looking at somebody who has hypoperfusion or shock, their color may be pale. If they have poor, if they're looking at somebody with circulatory collapse, you're looking at somebody that has poor cardiac circulation, they'll be mottled or ashen in appearance. So all those colors matter to us when we're looking for that general impression of our patient. We want to know if they're responsive or unresponsive, and indications of injury or distress. All those we're looking for inside that general impression. So severe respiratory distress. This is someone who is going to be presenting to you with an increased effort to breathe. They're going to have accessory muscle use. They're going to have abnormal breath sounds. The position of the patient. This is not somebody who's curled up on the couch with a little bit of bronchitis. This is somebody who's going to be trying to use everything they can to survive, including their position. They're going to be tripod and cyanosis. All right, cyanosis, if you see someone who's cyanotic, they've obviously been in severe distress for some time now, and it makes it extremely dangerous. That responsive patient, we want to determine their chief complaint and their quality of the patient's speech. Is this someone who can talk in complete sentences? Is this someone who can talk in 3-word sentences before needing to take a breath? Is it 1-word sentence, before taking a breath? Where are we at? That helps us to determine where we're at as far as difficulty in breathing goes. Inside your primary assessment, again, cyanotic or mottled. What's their respiratory effort like? Are they agonally breathing? Right? When we talk about agonal breathing, that's going to be someone who has a regular, sporadic, or shallow gasping breathing. That explains agonal respirations. If you had someone with an irregular pattern or rate, depth, with periods of apnea, well, that's Cheyne-Stokes. So what is their pattern of breathing? And that's super important. We're going to check for carotid pulse if they're if they have an altered mental status. If they don't have a pulse, we're going to start CPR. Is this someone who's just sleeping? Are they happen to be intoxicated? We just had a call. Someone talked to me about the other day that they were intoxicated. They aspirated, and it led to a cardiac arrest. So just being intoxicated, can't just say, "Oh, well, they were just intoxicated," right? Because if they can't manage their airway, it doesn't matter what the primary concern is that brought them there. Fact is, they cannot manage their airway. And do they respond to a voice, or do they respond to pain? So an apparently unresponsive patient, we're going to have to manage that patient's airway. We're going to have to assess it. We're going to have to evaluate it. We can't forget the possibility of a cervical spine injury, right? That's the reason why we have to get as much information as we can on the scene to figure out, is this someone that needs C-spine control or not? If it is, then we're going to need to use the modified jaw thrust maneuver or the trauma chin lift. Here's the modified jaw thrust maneuver right here. You see they're moving the patient to the floor. They're assessing and managing airway. They're opening the airway. Right? They're going to suction as necessary. Right? And so this is a portable manual type suction device that some services have out there. It's has some advantages. It's a hand pump, right? So you don't have to worry about a battery, which is a good thing because they seem to always be dead when you need them. But you also notice that the patient appears to be rolled on their side. So that's always important too. If your patient is aspirating, let's get them rolled on their side. If you have a C-spine problem, somebody can manage C-spine control when we roll them. But it's super important that we get them moved on their side, especially if there's so much vomit is coming out that the suction can't keep up with. Going to insert the oral airway if the patient's unresponsive and key there without a gag reflex, right? So if they're snoring, well, you're not going to be able to put an oral airway in, right? Most of the time, they're not going to accept it. Right, this patient needs to be someone who's totally unresponsive without a gag reflex. Ventilate the patient if they're not breathing or breathing inadequately. We're going to administer oxygen if the patient is breathing adequately but has indication of hypoxia. So, again, they had to have at least an inch of chest rise and fall to be able to bring enough air in through their nose and mouth down to the alveoli. If they don't have at least an inch of chest rise and fall, I don't know if you've ever heard the term peeing in the wind, but that's what you're doing. If this patient is in failure and you put a non-rebreather on them, they're not going to be able to get the oxygen for gas exchange. So suction the airway if you need to. Use the appropriate airway adjunct. You have two to choose from, an oropharyngeal or a nasopharyngeal, right? If this patient if they're snoring, right, they probably have a gag reflex. You have another tool. That's the nasopharyngeal airway. Insert one of those in, and that'll help your airway. We're going to be listening, and feeling for air, but especially, listening. Do I have any stridor sounds? Do I hear audible wheezing? What am I hearing? If they're breathing inadequately, again, excuse me. Get a drink of coffee here and keep that throat a little less dry. But, use your BVM if they're not breathing adequately. Ventilation is obstructed and reposition the airway does not help suspected foreign body obstruction. So you go to ventilate, right? And you don't get chest rise or fall. Well, reposition the airway. Make sure you have a good seal with the mask of the BVM. Try to ventilate again. If you don't get chest rise and you have a good seal and you could feel the resistance, then you need to inspect that airway and inspect for foreign body obstruction. Findings that indicate inadequate breathing. So altered mental status, right? That's something that could mean that our breathing is inadequate. It's not respiratory failure per se. It could be, right? But inadequate, right? This is somebody that we have to really look at and decide, critically think, and decide what does this patient need. We're going to look for the use of accessory muscle use. What is it? We're going to listen for those sounds that we talked about. What does their breath sounds when we listen with a stethoscope sound like? So ventilation rates less than 8 or greater than 30 in an adult. All right, that should be getting your attention. Now, I'm telling you, if the patient can move an inch of chest rise and fall, their chance of failure is 0. So, but when we look at a ventilatory rate, we're looking at a respiratory rate. We're looking for that. That should get our attention. If someone's breathing 30 times per minute, if they're not in failure, they're possibly close to it. So it should be getting our attention. Anybody with a pulse ox of less than 95%, some books read 94, right? But once you get to 94 or 95% on your pulse ox, you got to start thinking a couple of things. Either the pulse ox is not getting a good reading, right? Or the patient's in distress. End-tidal CO2, right? Remember, 35 to 45 is normal if they're greater than 60. What's their breathing pattern look like? And what's the color? Is the patient cyanotic? Are they pale? Are they ashen? Something to think about. We've talked about that. All right, clinical decision making. The goal of the primary assessment, right, is to identify those life threat situations and then correct them. The best approach to managing the airway is start with the basics and move up, right? I remember as a young paramedic, all I wanted to do was use my laryngoscope and intubate everybody I saw. And when I got older, I realized that was not the way to go. I realized that managing the airway is complex, and don't rush it. Again, once the oral airway is in place, the airway emergency is over. We're ventilating this patient. We can ventilate this patient for quite some time before we have to deal with gastric distension and things like that, right? It's okay, to start with that oral airway and move up, right? Move up. Later, put in your advanced airway. And in some cases, literature states with pediatric patients that an oral airway and a BVM is just fine without an advanced airway. Now, I get where they're coming from, but I think the issue here is the data. There's not a lot of data out there for that. They're not following a lot of data on that. But that's the latest science. Determine the presence of respiratory distress or failure. You need to do that quickly. And it's not hard to do if you are allowing yourself to get a good general impression of your patient. Takes a second to look at a patient's chest and make sure they have good chest rise and fall. And so if they're in distress, treat them with the appropriate oxygen. If they're in failure, we only have one tool to deal with that. That's a BVM. Decreasing level of responsiveness is a threat to the patency of the airway, and it is. Anytime you assess a patient with an altered mental status, you cannot turn your back on that airway. So here we have a clinical decision-making chart. Look, like when you go to responsive, there's a lot less. Look up here, though. Apparently unresponsive. Look at all the decisions that need to be made on this. And so let's look at responsiveness first. You assess the quality of the airway, breathing, and oxygenation. If it's adequate, apply the oxygen. If signs of hypoxia are present, right? And then come down here, inadequate oxygenation, provide supplemental oxygen, adequate oxygenation. If you come here and it's no breathing, start chest compressions and manage cardiac arrest. Assist ventilations, administer supplemental oxygen. But let's go over here where we have somebody who's unresponsive, no breathing and no pulse, start chest compressions, manage for cardiac arrest. They're breathing and pulse is present, check for responsiveness. All right, so then decrease responsiveness or unresponsive, maintain the airway and check for breathing. And then come down and then it's about adequate or inadequate. I'm not quite sure that, I guess these charts are good for some folks. But basically what they're telling you here is they're pointing out if the patient's responsive, they have a much better chance of maintaining their own airway. If they're altered, then you got problems possibly with the airway. You need to then look for chest rise and fall. If they have less than an inch of chest rise, they need to be bagged. If they have an inch of chest rise or more, and then they have signs of respiratory distress, you're going to have to do two things. One, treat that with the appropriate oxygen, whether it be a nasal cannula or a non-rebreather, right? And then you're going to have to reevaluate your patient. You're going to reevaluate their level of responsiveness and reevaluate for respiratory failure. At the end of the day, that's what this chart means. Secondary reassessment, just like I talked about, you want to make sure you have a 12 to 20 breaths per minute in that adult patient. Need to make sure that you auscultate breath sounds. And then we have the pulse ox, right? The assessment of oxygen saturation of hemoglobin in peripheral tissues. Now, maybe just a second, I'm looking for something. So when we talk about PaO2 versus SaO2, right? Or SpO2. So PaO2 measures the amount of oxygen dissolved in the blood, but your SpO2 or your SaO2 is going to measure the percent of hemoglobin in the blood that carries oxygen. We talked about breathing patterns here. These are your patterns to know about. I mentioned Cheyne-Stokes earlier, gradual increase and decrease in respirations with periods of apnea, right? And there's some causes over here, increasing intracranial pressure, brainstem injury, hyperpnea, normal rate but deep respirations. Again, it could be someone with diabetic ketoacidosis or emotional stress, apnea, right? Don't forget the definition of apnea. Bradypnea, This is someone with a decreased respiratory rate. And, we talked about drugs earlier. That could be a cause for that. Tachypnea, right? Fever's a big one there. Anxiety, exercise, even shock. Buyouts respirations. This is someone that has that rapid, deep respiration with gasp, followed by short pauses between sets. And usually someone with a CNS problem, your strokes, right? Your CVAs, your closed head injuries, and your spinal meningitis patients sometimes can do this. Kussmaul respirations. These are folks that go with really fast rates. And we got to think renal failure in these patients or diabetic ketoacidosis, some type of metabolic problem. Something else. So we talk about the assessment of the airway, ventilations, oxygenation, blah, blah, blah. We talk about lung sounds here in a second, but we're going to listen to lung sounds. We're going to listen to anterior, lateral, and posterior. There is a term I want you to be familiar with. It's called vesicular, Vesicular. And this refers to lung sounds auscultated in the mid-axillary region. So right here, mid-axillary region right here, vesicular lung sounds. Again, so we're talking about pulse ox use as part of that secondary assessment as well. I have opinion about pulse oxes. When I first started in this job 100 years ago, we didn't have them. A pulse ox should just make you feel good about your diagnosis, really. If you're diagnosing someone in severe respiratory distress, the thing you should be using that pulse ox for is to confirm how bad it is, right? If I look at someone, their tripod, their severe distress, accessory muscle use, I think I'm going to see a pulse ox less than 90, somewhere probably in 90, 89. If I pop it on and one or two things, either the patient is not perfusing enough to where I can get a reading, or it reads 87, 86. This should confirm my suspicion that this patient is one or two things. They're either in failure or they're knocking on failure's door. And so that lets me know as a provider, what I'm looking at matches what I'm thinking. But if they're not in failure and I'm looking at that pulse ox, it's at 87, then I need to be thinking, okay, well, I better assign someone to get the BVM out and be ready to use it probably soon. That's what a pulse ox should be used for. It should not be used really the way we use it. When we first arrive on the scene, we pop on a pulse ox to get a pulse rate, right? Because that doesn't tell me anything about the pulse rate itself. It gives me a number. And it may be accurate. It probably is accurate on the pulse number, but it doesn't tell me the rhythm and the quality of the pulse. And to be a really good provider, you have to really focus on those little things to make sure that really it goes a long ways in assessing someone by feeling their pulse. If it's irregular and fast, I know I'm probably dealing with an irregular rhythm. I don't know what kind of rhythm it is yet, but I know something's going on, and it perks my interest into the call. I'm more attentive now. I'm listening a little more. This just isn't the my stomach hurts call. This might have some legitimacy to the call. Capnography, right? So that's something that's coming around nowadays. It measures carbon dioxide in the exhaled air. Normal is 35 to 45. So capnography provides a waveform of the change in carbon dioxide. And so we can look, here is a CO2 waveform right here. It's not a very good one, right? But it is definitely, this is capnography right here. All right, talking about peak expiratory flow rate. PEFR is a measure of the maximum flow rate of air during expiration. Pay attention to that. You will see this definition again, and it's on expiration. Compare ongoing findings to baseline values obtained in the primary and secondary assessments. And then reassessment. Constant and regular reassessment is key with concerns of airway and breathing. Positioning and manual maneuvers. So when we're talking about someone who's in respiratory distress, and occasionally you'll run a call where you have a critically ill patient and they won't be tripoding, but they're in really bad respiratory distress. If we can set this patient up, the positioning is really going to matter with this patient and getting their airway management under control. Suction to clear fluids from that oral pharynx. And remember your manual head tilt chin lift or modified jaw thrust. This is called, remember, the recovery position. This patient is left lateral recumbent right now. And the reason they're not right lateral recumbent is because if you did that, they'll be facing the wall of the ambulance. Here's your head tilt chin lift maneuver. All right, so here again, the head tilt chin lift maneuver in the adult. In a neutral starting position, the head tilt chin lift maneuver in the adult. And final tilting position. Here's your modified jaw thrust. The head and neck are kept that neutral inline position. The mandible is moved forward and then up. So that mandible is moved up. It's moved anteriorly, right? And you got to remember these medical words, because when you're taking an exam, if this said mandible is moved forward and posteriorly, well, then you would be wrong, right? Because that would be meaning you would move it up into the back. So it has to be moved forward and then up or anteriorly. Remember, those noisy breathing could lead, that might be the clue that lets us know we have a partial airway obstruction. A harsh crowing sound of stridor. Now, when we talk about wheezing, well, that's a lower airway obstruction. Bubbling or gurgling noises could lead us to believe that we have fluid in the airway. So remember, if that patient needs to be on their side, that we do that. We use a gloved hand to sweep out anything that we can see. And suction may help after large debris and copious amounts of fluid need to be removed manually, right? So if you have a little bit of fluid, use your suction. If you have a lot of fluid, turn that patient on their side and use your suction, but sometimes you have to use your finger to really get in there and get that debris out of the way. Partial obstruction allows some air to pass, but a complete obstruction prevents any air movement altogether. If somebody's coughing, then they have air movement. Also, the inability to speak or breathe. Like I remember they used to teach, like in the Heimlich maneuver, they would say, "Hey, can you speak?" If they could not speak, then you would know, go ahead and do the Heimlich maneuver. That would be one of the first things. Hey, can you speak? And if they have that universal sign of choking where they're clutching their neck and they can't speak, that would let you know, okay, let's do the Heimlich maneuver. If they are coughing, don't interfere with it, right? Let them try to remove it themselves. In a conscious patient with that severe foreign body airway obstruction, use the repeated abdominal thrust to clear the obstruction. If the patient becomes unresponsive, then we lower them to the ground and we start CPR. We're going to allow that pediatric patient to clear his own airway by coughing. Conscious child with severe foreign body airway obstruction, perform subdiaphragmatic abdominal thrust in the same manner you use for the adult. Again, if the child becomes unresponsive, start CPR. Remember that the opening at the cricoid ring is smaller than at the vocal cords when we're talking about the infant's airway. Right? You have to remember that. And remember that when we're talking like a 4-year-old, the normal range would be 22 to 34 breaths per minute. And this is just basic choking when it comes to CPR. We're taught this. It's all American Heart. All right, so when we're talking about suction, though, we want to the suction to vacuum to remove liquids from the airway. And here's the introduction to the French catheter. And so right now you're familiar with the Yonker, the one that's the long, hard tip suction catheter, but maybe not so familiar with the French catheters. And so what you need to know there is that the larger the number of French units, the larger the catheter lumen. We'll talk more about it in skills. But that's used for suctioning the trachea. And you'll be trained in that. You'll be trained how to do suctioning from an endotracheal tube. Don't delay suctioning. It is an immediate jeopardy of aspirating fluids into the airway. The risk of suctioning, well, depending on what your patient's like, it could cause the hypoxia to become worse. There is a possibility of having trauma to the oropharynx. You can stimulate a gag reflex and make it worse. And in some cases, inducing bradycardia through the stimulation of the hypopharynx. Right? So, so it's all something, everything has risk and consequences with it. Suctioning too long can cause that bradycardia too. So you just want to make sure that you don't want to suction any longer than 10 to 15 seconds when you're doing that. And the minimum PPE when you're doing suctioning is gloves and eye protection. And this is just showing pictures of how oral suctioning is completed. Make sure that suction unit is properly assembled. You're going to measure from the corner of the patient's mouth to their earlobe. Open the patient's mouth, insert the catheter. Apply suction as you withdraw the catheter. So you don't go in guns blazing. Go in and then suction on the way out. Patients with endotracheal tubes require suctioning occasionally. And this is when you're going to use that French catheter. If it's possible, we're going to pre-oxygenate the patient. If copious secretions are preventing ventilation oxygenation, then we're not. We're going to suction immediately. You're going to assemble, check your equipment here. You're going to make sure that those, because since we're going into the trachea, we want to use a sterile suction catheter. You're going to measure, this is different than how you measure the Yonker. You're going to measure the suction catheter from the earlobe around the top of the ear and down the neck to the sternal notch. And the reason why you're doing that to the sternal notch is because this suction catheter is going to be inserted down that ET tube down to the carina. Remember that. Remember, that's where the suction tube goes. It goes down to the level of the carina. Yeah. That is going to be a recommendation. Use sterile gloves to handle the suction catheter. But unfortunately, not going to happen in our job set. You're going to insert the suction catheter into the endotracheal tube to a measuring depth without applying suction. See, it's going into that tube. Cover the side port and apply suction as you slowly withdraw the catheter using a twisting motion. You're going to monitor the pulse ox and the cardiac rhythm while you suction. You want to limit this to about 10 seconds. You want to ventilate the patient before suctioning again. If suction is to be repeated, we want you to suction with some sterile water through the catheter to clear it. See? So whatever's in there could prevent it from suctioning again. So we're just going to clear it with this sterile water. Suck some of that sterile water in there. Dispose of the use of the suction catheter by wrapping it around your gloved hand and put it in a red biohazardous waste bag. Here we have airway adjuncts. We have the oral airway. We're all familiar with this. Should be. We have a variety of sizes. Remember how we measure it. Ensure the oropharyngeal is the correct size by checking to make sure it either extends from the center of the mouth into the angle of the jaw, or my preferred method, like this. It measures from the corner of the patient's mouth to the tip of the earlobe. The cross finger technique to open the patient's mouth. And so there are let's see here, two correct ways to open the patient's airway to facilitate only oropharyngeal suctioning. And these two methods can't be used for ventilation, but you have the cross finger technique and the tongue jaw lift maneuver. So this is the cross finger technique. Insert the airway with the tip pointing to the roof of the patient's mouth. Rotate that 180 degrees, and the flange should rest against the patient's mouth. And then once it's in, they're ready for ventilation. We have the nasopharyngeal airway. We're going to use this when access to the oral pharynx is impossible, meaning they probably have a gag reflex. The sizing, essentially always lubricate this. Avoid inserting in patients with severe head or mid-face trauma or possibility of basilar skull fracture. So remember that. You'll see it again. Here's your different assorted sizes of your nasopharyngeal airway. Again, measure the nasopharyngeal airway from what? From the nasal tip here all the way to the earlobe. Lubricate it with that water-soluble lubricant. You want to insert the airway with the bevel towards the septum or base of the tonsils. Advance the airway into the flange as seated against the patient's nostril. And then we have the combi tube and supraglottic airway devices. And what I'm going to do is pause our video here, and I will use this on the next video. All right, so this is video number 1 of Airway.